Good evening, everyone. Myself, Dr. Sanjay Khatri. I am here to discussing clinical scenario today, shock management. Hope I am audible and visible. Give me 1 minute. So here something about Plus subscription. In Plus subscription you have advantage of daily live classes, live test and quizzes, structural course which suit to everyone, whether you are first year, second year, third year, FMG, NEET, PG, they have a structural course for everybody. And the most important thing, unlimited access. Once you come on this platform, you can see n number of classes of n number of educators. Yeah, most important feature, unlimited access. Now if you are fond of video lecture, go for iconic subscription, that is Unacademy and Prep Ladder, both in a single subscription. Unacademy and Prep Ladder both in single subscription. See the limited time offer. Yeah, iconic subscription for 40,500. Okay, so this is the fact. Go for it. Just 1 year you can take Unacademy and Prep Ladder both. Now PG, NEET PG, no date is there, but yes, something is there. It happened to be 3 to 4 months after. So take Unacademy for 3 months and get 1 month subscription free. So yeah, whilst you are subscribing, don't forget to use code Dr. Sanjay Life. Now this is Unacademy coming with. So MBBS foundation batch. If you are senior, tell to your juniors. If you are watching this, this is second year professional batch. So microbiology, FM, pharma and pathology by top educator. Make your foundation strong. Second MBBS 6-month course. And same thing for third year batch, again make your foundation strong. First year is already started. So PSM, ENT and Ophtha. 6-month course, alternate day classes 6 to 10 and 8:30 to 10:30 already started from 19th. Now if you are targeting FMG, Unacademy has a batch, and next 2022, yes, Unacademy has a batch. Now this is going on. NEET PG 21 images revision batch started from yesterday, that is 19th May. Yes, all the image we discuss important on the perspective of NEET PG by the top educator. Now if you come on this platform, you advantage to watch 34K MCQs curated by best educators. How to come on Unacademy? Once you come, then you decide whether you want Plus or you want iconic. If you want Plus, take it for at least 3 months. Whatever platform you are reading, come on Unacademy. Feel the difference. For 3 months, get 1 month free. For iconic, you need to take for at least 12 months. At least 12 months. Now come to today's topic after brief introduction. Now read this question carefully. Read this question carefully. Read this question carefully. 2-year-old child, large untreated boil on right thigh, comes in a septic shock. He started on IV fluid, giving 3 NS bolus. He developed basal crepitation. Shock continue. Administered a dose of hydrocortisone. Antibiotic, started on dopamine. Currently on dopamine 20 microgram. What is the next therapy? Shock is continue. What is the next therapy? This is a common clinical scenario. Come in the ward in ICU daily. Yes, 2-year-old child, 3-year-old child, 10-year-old child comes with shock after bolus. Child is still in shock. So what you will do? That you want to give albumin, butamine, epinephrine, non-epinephrine, and this is the purpose of today's class. Yes, we will try to cover which medicine you will give on which basis of shock. This is the purpose of today's class. Now see, shock. How you define the shock? Shock is a critical condition. Yes, everybody knows shock is a critical condition that result from inadequate tissue delivery of oxygen and nutrient to meet tissue metabolic demands. So tissue is not getting oxygen, that is the shock. Result of inadequate delivery of oxygen and nutrient to meet tissue metabolic demand, that is shock. Now one myth is there. The definition of shock does not depend upon blood pressure. Shock can be occur with normal, increased or decreased systolic blood pressure. My friend, try to remember this thing. It's a myth. Shock BP kam hi hoga. No, shock definition don't depend upon blood pressure. Shock can be occur with normal, increased or decreased systolic blood pressure. Decreased systolic blood pressure. Now shock can result from how shock can occur. Number one, inadequate blood volume or oxygen carrying capacity, that is hypovolemic shock or hemorrhagic shock. Child have excessively bleeding, goes into hemorrhagic shock. Child have dehydration, diarrhea, vomiting, yes, hypovolemic shock. Inadequate blood volume of oxygen carrying capacity. Now inappropriate distribution of blood volume and flow, that is distributive shock. That is distributive shock. We come on detail on this. What is distributive shock in other points. Now impaired cardiac contractility. You all know, if cardiac contractility is impaired, heart is not able to pump the adequate volume, that is cardiogenic shock. That is cardiogenic shock. And obstructive blood flow, obstructive shock. So basically shock divided into hypovolemic, distributive, cardiogenic and obstructive. Two shock is quite clear with their name. Hypovolemic, you all are clear, when volume is less, volume is lost, either dehydration, diarrhea, vomiting, or cardiogenic shock, the impaired cardiac contractility. So these two are clear, but yes, some query is there. What is distributive shock? What is obstructive shock? Now see, distributive shock comes under the category septic shock, anaphylactic shock, neurogenic shock. I am not going in the detail of feature of septic shock, anaphylactic shock and neurogenic shock. I directly come on the management, but try to give you the clear concept. What is distributive shock and what is obstructive shock? Yes, cardiac tamponade, pericardial effusion is there, massive pericardial effusion is there, so heart is not able to pump. Tension pneumothorax, duct dependent CHD, massive pulmonary embolism. These all are the example of obstructive shock. Yes, we will read the mechanism of obstructive shock also, management of obstructive shock also. The most important thing, fundamental, students comments, fundamental of shock management: optimizing oxygen content of the blood, optimizing oxygen content of the blood, improving volume and distribution of cardiac output, improving volume and distribution of cardiac output, reduction in the oxygen demand, correction of metabolic derangement. Each and every line has its meaning. Optimizing oxygen content of the blood. Yes, shock. First management, we try to give oxygen adequately. So oxygen reach to the every tissue. So give the oxygen whatever mode is possible. High flow, CPAP, maybe intubation. Improving the volume and distribution of cardiac output. Yes, if peripheries are cold, they are vasoconstriction. So give the drug which causes vasodilatation. Your aim to improve volume and distribution of cardiac output. Give the drug which increase the stroke volume. Reduction in the oxygen demand. If child has fever, child has pneumonia, so treat accordingly. Oxygen demand will automatically come down. and correction of metabolic derangement. Treat hypoglycemia, hypocalcemia associated with shock. So these are the fundamental management of shock. Take care of oxygen, redistribution of cardiac output, try to do the measure which decrease oxygen demand, and correction of metabolic derangement. Component of general management of shock. What are the things? Positioning. What position you will prefer? Anybody put in the comment answer? Managing a child, 2-year-old child, 1-year-old child with shock, with the shock. Yes, the most important thing, the position in which baby is comfortable. If baby is okay, it's not very sick, not hypotensive. If baby prefer to keep in the mother's lap, keep the baby in mother lap. The position in which baby is comfortable. The position in which baby is. Now, baby is hypotensive. Put in the Trendelenburg position where head and toe. Head is 30 degree below the toe. Got my point? Positioning. If baby is comfortable, put the baby is stable, put the baby in comfortable position in mother lap or on the bed, in the sitting or leaning. But if baby is hypotensive, not breathing well, put the baby initially in Trendelenburg position. That is, head is 30 degree below the toe. Then airway and breathing. Check the airway, ensure the breathing. Check the airway, ensure the breathing. Suppose secretions are there, wipe off the secretion. Give the oxygen, ensure the airway and breathing. And the most important thing in which pediatricians are thrilled, to get the vascular access. Yeah, that's the best thing. How correctly you manage the shock, how quickly you get the IV access. Child is very sick, don't be panic. Try to get IV line very quickly. IV line. If somebody is failed to get IV line by all the measures, veins are not good, child is totally hypotensive, then try to take intraosseous line. Got my point? Vascular access is the most important part when you treating a shock. Then fluid resuscitation. I will come on the fluid. What fluid you will give? Ringer, lactate, normal saline, blood, whatever thing is there. You want to give colloid or crystalloid, I will make you clear. Then first you get the IV line, then start the fluid. Then monitoring. Monitor the saturation, monitor the BP, monitor the pulse volume, monitor the urine output, then start the monitoring. So first make the position proper, then airway and breathing, then got the vascular access. No, it's not the prone, I am getting some comment, prone position. No, it's the Trendelenburg position. Then get the vascular access, give the fluid resuscitation and monitoring. Then do the lab study. Basic blood gas, electrolyte are the two major things which we want to do initially in the patient of shock. So you need to monitor saturation, BP, urine output. Got my point? So these are the points. Keep in mind management of shock. Then start the medical therapy. Initial, just concentrate on positioning, oxygen, IV access and fluid, and take the sample when you are putting the IV line. That is the initial management. Then identify on the basis of lab study or clinical examination what type of shock is this. Then comes the role of medical management, whether you want to give antibiotic, steroid, dopamine, dobutamine, epinephrine, non-epinephrine. I will make all concept clear to you. But these are the general management. First, positioning, airway, vascular access, fluid resuscitation, monitoring, lab study and medical therapy. Now fluid. Just push the fluid 20 ml per kg. You want to repeat? Repeat. At least repeat 3 to 4 times. 20 ml per kg over 15 minutes. When you think now your fluid is adequate, when patient develop basal crepitation or patient develop hepatomegaly. So give the bolus 20 ml per kg in 15 minutes. Pulses are still feeble, repeat, again repeat, again repeat. So how you come to know that you have given the adequate fluid or more fluid to be needed? Auscultate the base if basal crepitation is started and you find hepatomegaly is there. Stop the fluid. Now which fluid? Which fluid? This is the question mark. Crystalloid. What are the crystalloid? Normal saline, ringer lactate. Colloids. What are the colloids? 5% albumin. Fresh, frozen plasma. Plasma expander. Like plasma expander like, just a minute, plasma expander like dextran 40 or dextran 60. So what fluid you want to give? Yes, always begin a resuscitation with crystalloid. You can give either normal saline or preferably ringer lactate. Preferably ringer lactate. Always begin with crystalloid. Yes, which is better? You ask me which is better. Definitely. How we come to know which is better? Which stay in intravascular compartment more time. Yes, that is colloid. Colloid stay more time in intravascular compartment. Colloid stay more time. Crystalloid only 20-25% stay in the intravascular compartment. Rest will go in interstitial compartment. But what is the main advantage of crystalloid? They are easily available. When child comes in the shock, tell the sister, bring the fluid. Sister will automatically bleed normal saline or ringer lactate. If you want to give FFP, 5% albumin or plasma expander, you take some time to arrange colloid. So always begin your fluid resuscitation with crystalloid. Try to give 3-4 crystalloid bolus. Then if child is not improving, you can think of colloid, but first choice is crystalloid. Yes, if colloid are available, you can give, but 5% albumin is a costly affair. 20% albumin is a costly affair. Fresh frozen plasma you are not get readily available. You need to give, arrange from the blood bank. So yeah, colloids are better, but advantage of crystalloids are they are readily available. Got my point? So begin your resuscitation with fluid 20 ml per kg given in 15 minutes, normal saline or preferably ringer lactate. Now, septic shock management. I am not covering the hypovolemic management. Yeah, in hypovolemic shock you need to give fluid. In cardiogenic shock, discussion goes on tachycardia, bradycardia, arrhythmias. But the two things we will discuss here, septic shock and obstructive shock. What is the management? Each and every line is important. Listen carefully. Recognize altered mental status and perfusion. Give oxygen. Establish vascular access. Begin resuscitation according to PALS guideline. Means give oxygen, give fluid bolus. Basic thing. Then what is the third step? Monitoring and lab investigation. So go for VBG or ABG, lactate, glucose, calcium, culture and CBC. Over, get the IV line. So push the fluid bolus 20 ml per kg. Isotonic crystalloid. Got my point? Give 3-4 or more boluses. Clear until respiratory distress means basal crepitation or hepatomegaly develop. Septic shock. Patient come with septic shock. So first assess the mental status, give oxygen, get a IV line, send the blood investigation, give fluid bolus. then correct hypoglycemia and hypocalcemia if there, give first dose of antibiotic straight, then give hydrocortisone, and second vascular line for vascular support. One vascular line fluid will go, another vascular line dopamine, epinephrine, non-epinephrine will go. This is the basic management of septic shock which we should do in first hour. Then assess the patient, whether patient is in shock but patient is normotensive. What you will do, patient is normotensive, what you will do, give dopamine, start only dopamine. You get a arterial line, BP is normal, patient is shock, give dopamine. Now patient is hypotensive, BP is low but vasodilated, peripheries are warm, vasodilated, you are easily able to feel the pulses, but BP is low. Then what you will give? You will give norepinephrine. Now patient is hypotensive, vasoconstricted, peripheries are cold, then what you will give? Epinephrine. Am I clear? See, once you give the fluid bolus, give the antibiotic, give the hydrocortisone, but pulses are still, you feel patient is in shock, take the BP. If BP is normal, dopamine you need to start. If BP is low but vasodilated, BP is low but vasoconstricted, this is the basic thing. Vasodilated, we label it warm shock. Septic shock is generally a warm shock. But if vasoconstriction is there, then it's a cold shock. Then we start epinephrine. See here, I will clear you this thing. Warm shock, cold shock. Warm shock we start norepinephrine. Why we start norepinephrine? It is alpha agonist. What alpha agonist does? Alpha agonist increase the SVR, increase the contractility of heart. By increasing the systemic vascular resistance, it increase the blood pressure. By increasing the contractility, it increase the stroke volume. And that we want only in shock. What we want? BP will increase, stroke volume will increase. That's we want only. If warm shock, you need to start non-epinephrine. Why non-epinephrine? Non-epinephrine is a pure alpha agonist. It will increase SVR, which will increase BP. It will increase contraction, which will increase stroke volume. Cold shock, what you will give? You will give epinephrine. Why epinephrine? It is a positive inotropic action. And it has alpha and beta, both agonist. Now see, in lower dose, its beta action is predominant. What is the beta action? It vasodilate by decreasing SVR. Just listen, that we want peripheries are cold, vasoconstricted. So first thing we want, that should be dilated, and positive inotropic action, stroke volume reaches to periphery, so lactate level will reduce. Got my point? That's the purpose we use epinephrine in cold shock, because we want little bit peripheral vasodilatation. That by decreasing the SVR, in low dose epinephrine, it has a vasodilating effect. Decrease SVR, that's we want the extremities are cold. In high dose, it has alpha effect. Once start epinephrine with minimum dose, monitor the patients, you feel extremities are cold, it will gradually warm, then increase the dose of epinephrine. So alpha action will be predominant. Alpha action will increase SVR, which increase BP. So am I clear to you? In warm shock, we gave non-epinephrine. In cold shock, we give epinephrine. Am I clear? Am I clear? So one thing, let's see who are going to answer it. Who are going to answer this? If patient is in warm shock, you have given the non-epinephrine, not responded. Next drug. Vasopressin. Next drug is vasopressin. If not respond to non-epinephrine. Cold shock, patient not improved to epinephrine. Then what is the next? Next drug is you need to give non-epinephrine plus dobutamine. Dobutamine. Got my point? Shock will be clear to you. Septic shock. Septic shock. I am again repeating. These are the initial management. Simple. Recognize the mental status. Give oxygen, get a IV access and send the blood sample. With IV access, give fluid bolus 1, 2, 3, 4. Then correct hypoglycemia, hypocalcemia, give one antibiotic, give one steroid. Think about vasopressor. What is the choice of vasopressor? If shock is normotensive, give dopamine. If hypotensive, vasodilated, warm, give non-adrenaline. If cold shock is there, give epinephrine. If dopamine is not responded, next step is give milrinone. If non-adrenaline is not responsive, next step is vasopressin. If epinephrine is not responding, next step is non-epinephrine plus dobutamine. This is the key. This is the key. If you know this thing, now do the question. The question is very simple to you. 2-year-old child, large untreated boil on the right thigh, comes in a septic shock. Boil is there, comes in a septic shock. You have given the IV fluid. After giving 3 NS boluses, he developed basal crepitation, but shock continue. So you will got bolus is sufficient because basal crepitation is there, but shock continue. Then you, because it's a septic shock, you administered a dose of hydrocortisone, antibiotic, and started on dopamine. But shock continue. What is the next step? Septic shock treated as a warm shock. In warm shock, what we gave? We gave non-adrenaline. Yes, in the beginning of the class, few are putting very right, putting D, but this concept should be clear to you. How? When we start dopamine? When shock with normotension. When we start non-epinephrine? When warm shock. Hypotension with dilated, vasodilated. When we start epinephrine? Peripheral vasoconstricted, cold shock. What if not improve with non-adrenaline? This is the again question comes. We give vasopressin. I hope, am I clear? Treatment of septic shock. Now, anaphylactic shock, another distributive shock. Yeah, you may experience emergency sometime anaphylactic shock. Patient giving some medicine, some fume, some smoke, suddenly goes into anaphylactic shock. Okay, controlling life-threatening cardiopulmonary problem. Injection is given and child suddenly develop hypotension. Child suddenly develop choking. So what is the problem in anaphylactic shock? Threatening cardiopulmonary problem. Threatening cardiopulmonary problem. And why anaphylaxis is there? There is a mediator release. So our aim to reverse or blockage of mediators. Simple. Now make the concept clear. If you find it's anaphylactic shock, if we are giving the penicillin, we always tell do AST, skin testing. After skin testing, if skin testing patient develops some shock anaphylactic shock. So what we will do? We will give epinephrine first. Note the strength, 1:1000 strength. So dose is 0.1 to 0.5 ml for child. Okay, fluid bolus. Once you give epinephrine, it will take care of hypotension, it will take care of bronchospasm, mainly hypotension. Okay, then give the fluid bolus, give albuterol, nebulize the child because bronchospasm is there, then give the antihistaminic. Commonly we give Avil and give corticosteroid, hydrocortisone injection. This generally we do in the anaphylactic shock. When this shock occur in day-to-day practice, child is taken for CT scan, contrast reaction, suddenly rash appear over body, choking is there, BP is falling. Don't be panic. Give epinephrine, start IV fluid and give a shot of steroid or antihistaminic, what is easily available to you. Then start nebulization. If BP is still low, repeat bolus, repeat epinephrine again. Simple. Anaphylactic shock, epinephrine, fluid bolus, beta blocker, antihistaminic, corticosteroid. Am I clear? Septic shock, just mental assessment, oxygen, get IV line, send the sample, bolus 1, 2, 3, 4, dopamine, then assess warm or cold shock. Warm, give non-epinephrine, cold, give epinephrine. Anaphylactic shock. Now see, this is another a new term which we are not reading day by day. Obstructive shock. How? Duct dependent. Yeah, I will explain you. See here, this is LV. From LV, blood goes ascending aorta, descending aorta. Okay, now this is RV. RV, blood goes to the lung. But you noted here this is PDA. PDA. So PDA supply the blood from left to right, from aorta to pulmonary artery. PDA is there. It will close. PDA is a transient structure. PDA is a transient structure. It is closed. PDA is a transient structure. It will close. Physiological, 10 to 15 hours after birth. Anatomical, 2 to 3 weeks after birth. Now see, concentrate on second picture. Concentrate on second picture. See, this is LV. LV, blood is going. Just a minute. In the upper part of the body. See, arch is interrupted. Arch is interrupted. Notice, you notice here, arch is interrupted. Now see, lower limb is getting the blood via PD. Now think what happened if PDA get closed, no blood is going to the lower limb. Patient presented to us with shock. Why shock? Because there is obstruction here. Arch obstruction is there and upper limb BP is high because upper limb no problem will be there. Arch obstruction is there. That's the obstructive shock. Child is in shock. Why child is in shock? Because of obstruction. You got my point? You got my point? This is duct dependent lesion. Duct dependent lesion. Tension pneumothorax. Pneumothorax occur. So lungs are not able to dilate. Heart is not able to pump the blood for ventilation perfusion. So what happened? Child goes into shock. Once you diagnose it, do the needle decompression. Cardiac tamponade, collection of fluid around the pericardium. Okay, so child goes into cardiac tamponade. So urgent management, pericardiocentesis. Put a needle, do the pericardiocentesis. Why child goes into shock? Obstruction is there, my friend. Heart is not able to contract properly, not able to dilate properly, diastolic dysfunction. Tension pneumothorax, lung is not able to inflate properly. Obstructive leads to shock and pulmonary embolism. These all are the example of obstructive shock. In this class, my aim to cover a little brief about septic shock, anaphylactic shock, obstructive shock. In some other class, I will cover cardiogenic shock, where cardiogenic shock occur either bradycardia, tachycardia, myocardial dysfunction. So it's another full chapter. So the short one, just an idea when we start non-epinephrine, when we start epinephrine, how many bolus we are giving, what is colloid, what is crystalloid, what is the importance of getting a IV line. If you are doing in a working in an emergency, be expert getting IV line. Yes, never lazy, because whatever theory you know, if you are failed to put IV line in the child, all theory will be waste. So first work is your skill, and pediatrician, take my word, they are very good in putting IV line and intubation. So first oxygen and IV access, then we start with DOPA, DOBU, Milri, epinephrine, non-epinephrine, that we know. But first thing, oxygen and IV line. Yes. So this is the today's class, shock management. I am coming again tomorrow, 21st May, with vitamins deficiency. Good clinical questions on vitamin deficiency. And on Saturday, chronic diarrhea. Yes, generally we learn acute diarrhea. No, some severe dehydration, ORS fluid. No, chronic diarrhea is a known entity. I will cover chronic diarrhea in my YouTube session. Time will be same, 7:30 to 8 p.m. Yes, myself Dr. Sanjay Khatri. This is my Telegram group. If you are not there, be there. Yes, myself Dr. Sanjay Khatri. Keep reading. Let's crack it. Want to learn more from me? Come on Unacademy platform. Thank you. Bye bye. God bless.